pull up.
Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about ACL graft choices. A lot of debate of which is the best choice for specific clientele, specific athletes, genders. So we're going to discuss that, our experiences, some of the research behind it, and take it from there. But before we get into it, Brandon, how's it going?
Going well, Jer. This is a great topic, especially in lieu of our upcoming Mother of All ACL courses that'll be launching in a few weeks. We're ready in February. I mean, time is flying by.
Crazy.
This course is in 2 weeks, the 19th and 20th, or whatever that weekend is. Early morning episode today, guys, from across country. So I'm not at least drinking booze, but I'm drinking coffee. But I have this awesome cup that my sister got me when she was in Disney. It's a Genie One. All powerful greatness has been summoned. Very fitting. I will be summoning my greatness and my powers today for this podcast.
That's awesome.
And then quick shout out, her daughter, my sister's daughter, my niece, just had her 10th birthday 2 days ago. So happy birthday to her as well.
Oh, happy birthday. Which one is it? I think I met the whole squad.
Yeah, she's actually the oldest one by a couple months. It's Ayana.
Okay.
She's turning 10, so now a pre-teenager.
Oh,
so she's my sweetheart right there. So happy birthday to her, and then we have
happy
her birthday
birthday
this upcoming weekend.
Nice. Well, I'm also not drinking is early morning episode. Shout out to Rowan. I'm having iced coffee today. So
wintertime, bro.
Huh?
So it's the wintertime. You have an iced coffee?
Oh, it's raining out here. It's actually pretty warm out. I worked out this morning, so sometimes when I work out, I don't really want anything especially hot.
I got you.
Yeah, Rowan, shout out Rowan, as we're on Rowan's campus. So, but iced coffee to start off the day. But yeah, I guess to kind of get it going now that we don't have any alcohol to talk about or rate. I don't think I'm gonna rate my coffee. It's pretty even keel here, but Brandon, anything let's I guess first talk about experiences or anything like that, maybe a preference to begin it, and then we can kind of talk about the nitty gritty of specifics of ACL grafts and everything like that.
Yeah, I mean, I'd say that to start, a good baseline is to understand what's out there, and the top two would be your patella tendon graft and the hamstring graft.
Mm-hmm.
You also have your ACL graft, which would come from a donor. In the end, just so you guys know, I mean, this is a decision the surgeon's going to make.
Mm-hmm.
And if it's a really good surgeon, probably the surgeon and the patient, maybe the surgeon might educate the patient on why or why not they think we should go with a certain graft.
Mm-hmm.
Different hypotheses out there, and you're the sports PT, and obviously ACL is a passion of yours. If you're a sprinter or a runner, they recommend the patella tendon one, so you don't lose some hamstring strength. You might lose about 5% of hamstring strength, after a hamstring graft. So they may recommend that, but unless you're an elite sprinter, does that matter? Those conversations are there. So I'll let you handle that. And then maybe the older patient that's perhaps not as athletic or not as active, maybe they get the donor graft, but understand there's complications, rejection, maybe some infection, things like that might come along with that one. So these are all things that maybe you should be aware of as a PT to understand if you're getting one of these, what are the likelihoods and the ratios and what type of outcome to expect. Or if a patient's coming to you unsure of what to get and things like that, you can now have this conversation with them. And I think regardless, and Jeremy, you might have some stats on this, we'll talk about the re-tear rate of ACL in general, and the re-tear rate, and then the return to previous level activity is not as high as you would think with such a gold standard of a surgery that is done and so highly coveted. So much research, time and money, resources have gone into understanding this type of injury and surgery, but yet our outcomes aren't where they need to be. And does that fall on us as the PTs, on the surgeon, on the patient, all the above? Where do we fit into this? So I think that's where we should really be, I guess, start with this conversation, actually even progress into the conversation. But what's your experience? What do you like? What are you noticing on type of re-tears and things like that?
Yeah, and I think this is where it gets important, on the importance of, I guess, emphasizing prehab. I think a lot of people think, oh, prehab, it's a time, just strengthen the muscles and, strain the knee or get the range of motion and prep them for surgery. I think prehab is the most important part just for education purposes, to discuss mostly, graft choices and then just mental preparation for the surgery and the whole phases and the whole journey of ACL. Still to this day, it still baffles me that most people they get the surgery and had no idea what to expect of just the rigor of it and or the length of it. Like I've had some people go in and they're like, well, I thought I'd be done in a couple months. I'm like, this is ACL. I thought this is like common knowledge. I figured they
Yeah.
teach you at high schools at this point.
Mhm.
So I think it's important, based off of what Brandon was saying, use this as an opportunity, if you can, to discuss potential options for graft choices. Obviously, as Brandon mentioned before, it is really up to the surgeon. But you can, I've swayed some patients some ways. I'd say actually a lot of the most recent ones I have. As Brandon said, the most two popular ones are that bone tendon bone of the patellar, or I'm also seeing quadriceps is becoming more popular. I think the last two or three I've had have had a quad tendon autograft. Still up in the air with it. My first one, which was just at the start of COVID. I guess I had left a bad taste in my mouth. He's great. He's playing semi-pro basketball. So he advanced himself to a higher level of playing. He also had an ALL repair and a meniscal repair. So he probably had a lot more going on, and that's probably why like things were a little bit slower initially, and that's probably why I was a little against it at first. But yeah, you have the quadriceps, the patellar tendon, which is, I believe, the gold standard, and then the hamstrings allograft. And now we have something that I saw at a conference, it's like probably 2015, 16, the bridge enhance ACL repair, or the bear, which they're trying to take the, like, your native ACL, taking, string, essentially repairing it, which is pretty difficult. And very, very few select individuals. It has to be a timing thing to do. Some of the earlier outcomes for it seem to be better, a little less intense in the earlier stages, and a quicker return to certain things of, getting back into like running and such, which a lot of people are like, oh, it's 3 months, but reality, it's probably 4 or 5 months. But these individuals seem to kind of respond quicker. It's a little less intense on the knee initially. But overall re-tear rates, I think, have been pretty similar even amongst them. I have to look more into that. There's really not as much literature on that. But yeah, going into that, we're talking about,
Real,
stats. Go ahead, Brandon.
real quick, with the hamstring, what muscle, just for our audience, is most commonly, or what part of the hamstring is the graft most commonly taken from?
They usually take the semis, or semintendons, and the
Seminosis, yeah.
gracilis. So a
Mhm.
lot of people just think it's just that, but the gracilis gets involved as well. So knowing that, that's something to incorporate into your rehab. They say there's like a sweet spot at the 6 to 8 week marker, where you shouldn't go essentially ham on hamstrings for your post-op hamstring autografts, just because it's, reintegrating and that sort of stuff. The likelihood of injury to the hamstring itself gets increased. But yeah, in my opinion with that, especially for female athletes, they're typically having difficulty with, posterior chain and hamstring. So Is it something that we want to pull more out of? You're taking a good chunk, especially your double bundle. So
Yeah.
there's a single bundle, double bundle. The double bundle, so you're taking essentially, your hamstring tendon and then you're doubling it versus a single.
And that's been
Obviously,
equated to being like the gold standard 1B, the double bundle to the patella graft.
yeah, I
What
think
I
the
read
double
anyway.
bundle is superior to the single bundle. And there's some studies on the tensile strength
Yeah.
of the graft choices. And in theory, the double bundle, I believe, was the most superior. Like compared to a native, a patellar tendon, a single bundle, double bundle. I don't know if the quad tendon was in that one. I can't remember. I just remember who was the winner. Um, the double bundle was the most superior. Re-tear rates, though, amongst them all, they're pretty similar.
Yeah.
Um,
Why do you
amongst
think that is? I don't know if I'm digressing here, but
no, this
we're on
is
retail rates. It's a big, I mean, I think underreported, right? What's the stat, like 25 to 40% retail rate,
yeah.
right? That's pretty high. Like on the high end, we're talking, 40%, almost 50%. That's retail. That's a retail rate for one of these. So where are we missing this? Are we choosing the wrong patients to get surgery? Should we opt with the COPA route, or is our rehab failing them? Or are we progressing them too fast and letting them return to sport too quick?
I think it's a combination of all. I
yeah.
think you hit the nail on the head on. I believe those are the big points of why we essentially suck at. I really don't think. I mean,
It is what it is. Say, man, we as a
we
whole,
do.
the therapy profession is not progressing this type of patient well.
No, and if you look at the study, I mean, only 55% of people return to their previous level or their elite level.
Yeah.
If they're not elite athletes, it's 40%. So 40%. That's
Half.
worse than a coin flip. So should we be telling people this? Like, yeah, you'll get the surgery, but there's only half a chance that you'll actually get back to what you were doing. And that's definitely not the perception. Most people perceive that 90% of individuals who get the surgery perceive they will be back to almost completely normal. And that's definitely not the case.
And they think they're going to be back in like 2 months.
Yeah. And that's,
like,
I'm like,
and they're like, I have a brand new knee.
yeah.
No, you don't.
Yeah. No, it's reconstructed. It's not revamped. It's not enhanced.
Yeah.
So
We're not there yet in our technology.
no. I mean, we've definitely made some headway for sure. I mean, you look over the span of the years, it went from career ending to a 2-year process to accelerated, where we're trying to get them done in 6 to 9 months. And we then found out that no, we suck at this. This is not good. We're causing more tears. Back down to like a 9-month to 2 years. So like the Moon group suggests, Moon is part of like HSS and some of the studies that especially adolescents should be 2 years. Like we're clearly not figuring out. And over all these years, really the numbers haven't changed. And unless you're in an area with a surgeon that's maybe doesn't specialize in ACL reconstructions and stuff like that, I haven't seen a ton of like complete f-ups from a surgical. They do happen, put the graft in too vertically, you don't follow the footprint, infections, whatever it may be. But I believe a lot of it is what Brandon was saying. It's on the rehab side of things. Are we pushing our patients enough? Are we assessing them to make sure they're ready for return to sport, and especially assessing them often? Are we preventing all the bad things that could happen down the line early enough? I think there's not enough training. I don't know about you, Brandon. In my PT school, I think it was maybe mentioned for about an hour, maybe. I don't even know if it was an hour, to be honest. Not knock on my school or anything like that. I love them dearly and that sort of stuff. It's not, obviously they got a million things to teach, and ACLs, one of them. But it wasn't that much. And if it's one of the top orthopedic procedures, should we invest more into it? Or, obviously going into it after, post-doctorate work, because it is something that requires in-depth knowledge, in my opinion. And I believe that's the reason why our outcomes are not that good. I was doing a recent thing on our outcomes, like my personally, we're in the upper 90s. We've had our couple issues, and I'll mention that during the course because I'm a man who believes on learning from mistakes and stuff. But what are we doing different? Is it just luck? I think over a span of 8-9 years we can kind of push past luck. But it's I think it's tying in all these sort of things. And me personally, again, we talk about graft choices and that sort of stuff. At this point, I don't really care about graft choices. I'll deal with whatever I get. I did have a tibialis anterior graft once of an allograft tendon, which was pretty weird. And I'm pretty sure that individual was extraordinarily lax in the beginning. I thought he had posterior lateral corner injury as well. And I kept trying to tell the surgeon at the time. And this is going way back. And the graft failed. Like he didn't have an incident, but just nothing worked. And then I told him to go see a second opinion, and he was like, it's really not even holding up together. So besides that, whether you're a quad, a hamstring, a patellar tendon, haven't got a bear yet, it's really the rehab, in my opinion. I'll put it all on our shoulders. I'll be a man enough to admit it, as long as they're not coming in completely jacked up. And we've had people with 30-degree knee flexion contractures, and we've managed to make it happen and get them back to sport. And I used to think that's never possible. So it's reality of like what you're doing, and I think that's especially in the earlier phases. Versus anybody can do sport specific stuff, which is telling them to play their sport. And all those funny, fancy stuff. And we do that sort of stuff, but it's getting to that point, I think, is where the real bread and butter, meat and potatoes are at.
Yeah, give me 1 second. I'm actually trying to pull up because you talked about rehabbing and timelines, and I'm just going to pull up a generic protocol here. I think we as PTs rely too much on these protocols. Don't get me wrong, we have to respect the surgeon. They know what's going on. They've created these protocols for a reason. There's validity to them. That should be a part of what you consider a part. Keyword. It's going to vary patient to patient. Not everyone's going to follow the same timeline. You need to be able to identify, the patients that are lacking, and maybe the patients that can progress through things maybe a little faster, but also those ones that can progress fast, to pump the brakes because you don't want to put too much stress too soon. All right. So you can't just solely go by the protocol. I mean, what are you going to do? A patient comes in, you follow the protocol to a T, you're a little negligent, you do something and be like, oh, I just followed the protocol. I mean, that you can't base your decision making, especially as an autonomous practitioner, on I just followed the protocol. Like, there's no rationale with that. What about the patients that you don't get protocols for? Like, a ton of those, they just come in, right? And this is not even just ACLs. This is any type of surgical protocol. Shoulders, I think shoulders and knees are probably like the two most common surgeries where we don't have a protocol. We rely too much on it instead of understanding, like Jeremy said, markers, impairments, timelines. Again, these are generalities. Like, our biggest predictor of if the patient gets knee extension is their extension preoperatively, if I'm saying that correctly, if that makes sense, right? So what type of extension they have before they go into surgery. And that's where Jeremy was talking about, a lot of it is prehab, right? We need to get these patients, at zero, at least, there before we send them in. Do they have good quad control, right? If they don't have a lag, again, that's another indication of if they're going to be successful. Do they have good quad control pre-operatively? If they don't have those, they need to not be going to surgery first. And I think that one's on the surgeon.
Yeah. I've pushed back the surgery. Pushed back the surgery and recommended one to be pushed back.
Yeah.
And the patient went ham. Like, I was just like, I don't think you're ready. It's wouldn't be in your best interest. And it was over like a COVID sort of like exposure. This was like exposure. Remember exposure signs? Like everybody was exposed, so it came away.
Yeah.
And it was like Delta, early Delta. I can't remember which freaking variant. But I was like, listen, you're good. You got exposed. You weren't getting the therapy. I've measured some things. I don't think you're quite ready. And then she spent like next 3-4 days getting ready. And the surgeon was like, no, you're good to go. But there's been other times where I've made the call of like, let's give it a couple more weeks. It's not worth it. But look at Saquon Barkley, and let's talk about how his career has ended up. He waited over a month to go, and he's in the NFL, and his quads are bigger than my entire trunk. But he waited over a month because I assume he wasn't ready.
Yeah. Going to athletes. So I think the worst thing we keep doing, is comparing to professional athletes or collegiate, high level collegiate athletes. AP, I think we've said it before on the podcast, is the worst thing that probably could have happened to ACL surgeries. Oh, he came back in 8 months. And that's that timeline, because that surgery was over 10 years ago, where we began to, this can be done faster. No, he's the outlier, not the norm. Right. He's also rehab. Besides the fact he's a genetic freak, he's rehabbing 13 hours a day. There's no ordinary patient that we get that's rehabbing 13 hours a day. You're lucky they rehab, 3 to 5 hours a week.
Yeah.
That's probably less than 1% of a total week's time. Those 3 hours you get with a patient, or 4 hours, even if you're nice, and let them stay longer just because it's good for their care. Back to the knee extension thing. Here's a stat: 48% of patients with knee extension loss at 4 weeks require arthroscopy to achieve normal extension. So now they're going in again to clear up scar tissue and things like that because they don't have it. I want to touch back to what you're talking about, Jeremy. If tunnels are not drilled properly, and this is a little clinical pearl for you and the audience here. If you guys are studying for your OCS or SCS, if a tunnel is drilled and ACL is put too vertically, what's going to happen? Right, they're going to get locked at 90 degrees and not going to be able to break 90 degrees. So that's that'll be on one of your tests if you guys are studying out for board certifications. If you guys want to specialize in ACLs, that's a clinical pearl. Just know and understand. You want more information on this stuff, go to Ortho Bullets. It's free. I did a lot of my time studying on that website. It's really actually made for surgeons. Bunch of good cases there, but you're studying for a board certification. You want to go the extra mile and understand the other side of things, the surgical side of things. It's a great resource for you guys. So Ortho Bullets, and I have no financial interest in them. Just sharing some knowledge out there for you guys.
Speaking of surgeries, I think it's always a good idea to, especially for really for anybody with a surgery, but to get the op report, not just the script and the protocol, because you'd be surprised on how many people actually think they have a graft, a certain type, and then you're looking at them like, that doesn't look like the normal incision area, and you look at the op report, it's like a different one. So sometimes they send in the wrong protocol. And it's always good just to see what they did. A lot of the protocols or the scripts are just like, left ACL, hamstring autograft, and then you read the op report and they're like, they had a meniscal repair, they cleaned up some chondral lesions, and that's not reported. And you're starting to wonder, like, why is this person off to a slower start, or whatever it may be? Why is there more swelling here? So that's always a good idea. Speaking of some other things in the surgical realm, and Brandon brought up, loss of extension and everything like that, the infamous Cyclops lesion. Maybe we can have a separate episode on that. But a lot of that, I believe in a study that might have been Shelbourne, people who didn't have their full extension, symmetrical extension, not even just to zero. So if they're hyper on one side, hyper on the other, I think they were 2.3 times or 5 times at risk for a Cyclops lesion. So Cyclops lesion is, especially a difficulty in extension, more pain in the anterior aspect. It's like scar tissue, typically in the mid substance of the ACL. There is some people are asymptomatic and have it. But I was listening to recently a podcast, maybe it was JSPT or something like that, Eric Mira, who's a sports PT, and he was saying, that Cyclops Lesion, and they come and they go, like you just get them or you don't get them, sort of thing. And there's plenty of studies that actually argue that. I would say clinically, not to say we're, God's gift to the world, never had a presence of a Cyclops lesion, never needed a MUA on anybody. And his thing is like, oh yeah, they come, whatever it may be. I think it's not a chicken or egg thing. It's if you're not doing the right things, and I'm gonna knock on wood, so hopefully I don't get like 10 Cyclops lesions starting next week or something. If you're not doing the right things early on, and they have maybe hamstring hypertonicity, lack of extension, whatever you want to call it, and they're not walking on it right, I think that Cyclops lesion develops. That's me. I don't have anything to say to prove that, but we know individuals that don't get full extension end up getting that. So that's another thing. It doesn't matter what graft you have in there. I don't think there's been any research to support one graft develops Cyclops lesions to another. I think it's really what you do in the earlier stages, and that includes pre-op and those early couple weeks. But on the topic of surgeries, I get heated about that whole concept.
Yeah,
Like
obviously. No, it's great, Jared. This is a great podcast to have. This is your baby. Obviously, you created a stellar course coming up, which I'm pumped about. It obviously is your passion. So please rant away. I really think PTs need to spend more time in the boring phases. As we're having this conversation, and I have my resources up and just kind of thinking out loud, and just seeing, like, I have we have a patient now. It's not mine. It's in the clinics, but he was somewhere else before, and he's at 5.5 weeks. He's lacking extension. And, a conversation I was having my PT who's treating him is like, hey, we need to focus on these two things only right now, motion and his quad lag. And it's a subtle quad lag, right? Where probably most PTs would just, all right, yeah, let's move on to the next thing. It's close enough. Like, no, we need to spend more time on the boring phases. Make sure you get full knee extension and not just zero. Like you said, it has to be symmetrical to the other person's knee, right? We all have differences. And then that knee extension. And also phase 2, building up adequate strength, building up motor control, building up endurance. I think, everyone loves the allure of, sports PT. I want to work with athletes. I want to do the fun stuff, right? Cutting, agility, pushing them, juking, obviously you post a lot of videos of, your later phases where you're trying to mimic, in-game scenarios and in-practice scenarios, but you can't do that at the expense of lacking the foundation and basics. Circling back to trying to speed this rehab up. I mean, this is really 1.5 to 2 year injury and recovery. Even professional athletes say it's not till their second year where they start to begin to feel normal again, right? There's a religamentization process, yeah, I said that right, where that graft needs to undergo and change properties, right? That just takes time. There's no way to expedite that. Quadriceps deficits up to 44%, probably close to 50% deficits of quadriceps strength at the 1 year mark. That cuts in half by year 2, right? So that's at 12 months, but yet we're ready and rushing to have this patient run and do agility and cutting and jumping by 3 to 4 months.
Yep.
Why? Because it's fun. It's sexy, right? The patient doesn't want to spend all this time, 2-3 months doing boring stuff, but that's the stuff that's going to make the rest of the rehab process easier. Yep. And then as it comes to us and utilizing some tests and metrics, some KPIs, Val Sport Cord test, the LESS test, the Y balance test, try and get as much objective data to see if they're symmetrical left to right side, before we really start progressing these patients and returning them to play in sport. Even some of those return to sport protocols, and Jeremy, you and I have had discussions on this, and we're like, no, I don't agree with the research, where a triple hop test and triple jump test and single leg hop test and all those jumping tests, 85% symmetrical. That's all they require before they go return to sport. 85%, no.
It's not good
I
enough.
want in the 90s, and me personally, I say 95%.
Yeah,
That's
I've
my
recently bumped
threshold.
up to 98. I
You,
was like
well, you
95
even
for
go
a while,
98.
and I'm like
Yeah, you
98.
even go 98. And,
Yeah.
you know, if you can't be symmetrical, then breaking that down to the patient, you're putting yourself at greater risk.
Mm-hmm.
They may not like you. Fine. You don't like me. You want to go somewhere else. You know, you want to roll the dice, go ahead.
Mm-hmm.
But then they're going to be coming through your doors again. Or they
Yeah.
probably just choose another office because they don't want to go tell you that you're right.
And
But
that's got to be the most heartbreaking thing is like you didn't do your due diligence, let's say in little things. Oh, close enough on their knee extension. All right, great. You know, let's keep going. We've done this long enough. Or, you know, it's their numbers are good enough. You're only cheating yourself. And, you know, in that case, as a clinician, you're cheating yourself as a clinician, but you are really cheating the individual. And you're putting them at risk. And if you phrase it that way, I'm gonna let you go. But we know we're at risk that we're putting you at risk. But I'm okay with that. You're okay with that, right? And if you phrase it like that, then most people will be like, no, absolutely not. I do it in a nicer way. I just say, listen, I really care about you. We've grinded it out for whatever, how many months, 8, 9, 10 months. You know, there's still some things that I think would be beneficial to work on. You know, go do everything with the team, go do this and that. Just let's not go to a full game or whatever it may be, or set things. I give
some
them battle
boundaries.
plans. And I'm like, all right, we just need to keep working on this, need a little bit more time. You had this, that was an extra compounding factor or whatever it may be. But yeah, don't F over your patients. That's it, you know. Whatever it may be in the earlier stages or the very, very final stages. You know, Brandon hit the nail on the head where it's like, yeah, it's nice to do all the sexy stuff, but that's not really necessary for us. I mean, we do it in my facility because I have the means to do it and everything like that. But the real bread and butter, our real worth is the earlier phases, if I had to be honest. And that's another limitation is like, yeah, you can look up all this stuff on social media and hell, you can follow us and you can see some cool exercises here and there. We put, I think once a week is like these weirdish sort of combination of something we want to do plus an impairment that the patient has. But it's really the, you know, what makes the patient, how they get to that point is all those earlier phase stuff and knowing how to manage it from a, you know, joint perspective, neuro perspective, psychological perspective. And I think that's, you know, gravely missed. Really, I've heard some PTs that are like all the way to the end. They just keep it boring as can be, is hinge, squat, deadlift, and just keep building strength. And they let the patient do the stuff on the field with their teams. And that's fine. But they got to that point by making sure they hit everything early on. But
yeah, Jeremy, you brought up a point, and you know, phrasing it. I'm actually okay with the way you phrased it. Hey, you know, you still have some deficits which are going to put you at risk. Are you okay with that? We'll just kind of return you. And they're like, no, like some patients need to hear that. And I think as PTs, and I've had this conversation with a different clinician of mine, younger, just starting out, but like, you know, he's trying to be their friend and joke around with them and stuff. But like, what are you missing by doing that? And you need to be the medical provider first. If you need to put the brakes on, put the brakes on. Don't rush them back just because they want to go back. The patient doesn't know what's good for them.
Yep.
All right. So not, you know, again, you want to try and meet them where you can. But if you're meeting them where you can because you want to just be nice and you don't want them to be mad at you, you're doing themselves a disservice. Like, in your professional opinion, you have to kind of stick to your gun sometimes, and sometimes it's you being the bad guy, but it's for the best interest at the patient. So, you know, especially younger therapists, you guys need to understand that you can't just not want to be the bad guy and say yes just to appease them to make them happy. Like, no, they'll get over it, and they'll realize that what you're saying is for their betterment. Trust me, that's way better than you saying, hey, go back, and then they go back way too soon and they blow out their knee again. All right. The stats are high enough. We just showed you the stats, you know, 25 to 40 or 50% retear rate. That's already high enough. We don't need to, predispose these people even more to it because we didn't do our due diligence or we're too scared to be the bad guy. We have to lay things out for people.
Yeah. Or even re-tear rates. Yeah, I mean, not re-tear, contralateral tears, or 30% of that. So that's even, I mean, imagine how heartbreaking that is. You do one
I
and
had a
then you
patient
tear the other.
years ago. Tore his other side. We rehabbed the crap out of him. Thought we did a good job, measured everything. He was just playing pickup football with his friends. Probably about a year and a half later, just under 2 years. It was a little more than a year and a half, but just under 2 years. Tore the other one. I was like, geez, and now I'm looking at, well, all right, what did I miss? Where did I go wrong? Was this avoidable? Some things are, some things not, but you should at least be questioning yourself, where could you be better?
Yeah.
Everyone
listened at that point, a year and a half later, contralateral tear. And Brandon, was there anything, what could have he done better? What could he have done? Terrible English on my part on live stuff, but that's the way we need to think about things. I think too, we don't take enough accountability for contralateral tears, re-tears. When those stats out, I'm gonna put up for my course and everything like that, I count those. There's an individual that unfortunately tore at 4 months in the rehab. After I was adamant about like, hey, make sure you're not doing anything, everything that you do in the clinic. And he decided, like, his friends were playing basketball and he's like, I just need to do it. He needed it for his own psyche, and he did it, and he re-injured, and that's my fault. Even though I was adamant, I'm always like, hey, listen, especially in the earlier stages, once you get to 6-7 months, everything's looking good. I'm like, hey, I'll reintegrate you into practice and that sort of stuff. But I didn't say the right combination of things to make sure he didn't go and do something like play with his friends and everything like that. So like, listen to that, those sort of things. Some clinics, all they see is ACLs. It's like, I don't care if they're re-tears, a couple tears. No, take some ownership of, really, do self-reflection. We always talk about self-reflection. Look at your ACL stats if you see enough of them. Even if you only see 2 or 3 in a year, look at them. How are they doing? Are they fully back to sport? Did they suffer any injuries or other injuries, even things unrelated to the ACL? Take some accountability. Try and get, as close to 100% of returning to previous level and no other injuries. So I thought that was a great point and a great accountability. And I think that's a theme of a lot of our podcasts, is accountability to ourselves and to our patients. So great job, Brandon.
Awesome. Thanks, Jay. I think it kind of wraps up, unless you have any other clinical pros. I mean, obviously this is a topic we can talk for hours on. We are going to be talking for hours on it in a couple weeks with a 2-day course. But unless you have anything pressing, I think that's a good point to stop. And if you guys are in the New Jersey, South Jersey, Philadelphia area,
Maryland,
go on our website, iosmt.com, and sign up for our 2-day course. Jeremy put a lot of time into this, and I'm excited for what we have in store for you guys.
Yeah, we'll be going through everything from imaging to video breakdown of injuries, just in case if you're more sports like on field and you just don't know how to recognize it. A lot of your ability to know when the test is recognizing that looked like an ACL tear, to the prehab, to the manual therapy, to performance-based manual therapy more further down the line, to strength and conditioning, power development, all this sort of stuff, and all the nitty gritty research that I'm sure you guys are all gonna love. And also psychology of things, because I think that's truly important. You can't have someone who's been taken out of their sport for 9 months to a year plus, and I expect them to have some psychological disturbances of sorts. But hope to see you guys there, and thanks for tuning in, and cheers, everybody.
Cheers, guys.